Hi students, I'm here to talk to you about Mr. Papadakis, who's brought in after fainting, and I think it will be most helpful if you read the case before listening to this recording, so please do that. So he's a 72-year-old man who's brought into the emergency room by his daughter after his daughter witnessed him fainting, so that's really helpful that you have a witness to describe this. And he then was down on the ground for about 30 seconds, and then he awoke. There wasn't any seizure-like activity, and he has no recollection of the event. So it tells you that he really was unconscious during this episode. So let's back up and talk about the definition of syncope. Syncope is defined as the transient loss of consciousness due to decreased cerebral blood flow, most commonly from a drop in blood pressure. And by definition, there's spontaneous recovery of consciousness. The most common etiologies are neurologic causes, such as what's commonly known as vasovagal sympathy, which is definitely the most common cause of syncope, and then seizure, orthostasis, so orthostatic hypotension, someone's dehydrated, they stand up, their blood pressure drops and they faint, and then cardiovascular causes of syncope such as arrhythmia or structural heart disease. So you guys don't need to know this for the purposes of this case, but I just wanted to give you a little background on syncope. So Mr. Papadakis didn't have any aura, so less likely seizure. He didn't have a sensation of lightheadedness prior to the loss of consciousness, so less likely orthostasis. He didn't have any palpitations, which makes arrhythmia maybe a little less likely, but can't rule it out. He didn't have any sudden shock or pain prior to the fall. That is a cause of vasovagal syncope. He wasn't confused following the event, so he didn't have any postictal confusion, which would suggest seizure. He did not have that. He didn't have bladder or bowel incontinence, which can happen during seizures. And he does remember what he was doing right ahead of time. He was walking towards the bathroom, and then all of a sudden he was down. So there was not really any prodrome. So it seems like vasovagal syncope is less likely here. Overall, he's healthy. He seems to potentially have a history of hypertension that really hasn't been treated. But when you talk to him a little more, he's had some concerning symptoms of chest tightness and shortness of breath with exertion recently, and they've been getting worse. So this suggests potentially an angina. And then he has some orthopnea. He's sleeping on 3 pillows at night, and he feels short of breath if he sleeps flat. And he also has some ankle swelling. So he's a pretty functional guy at baseline. He's independent in all his ADLs. He is an active smoker, and he's been a heavy smoker for a long time. On review of symptoms, he has potentially some dental problems, and he does report occasional palpitations in the past. And then we already talked about his other cardiovascular symptoms. It sounds like he might have an enlarged prostate, so he has some nocturia, and he has some hesitancy, some difficulty getting his urine stream started, and then some bilateral knee pain that's chronic. That's real common in older people with osteoarthritis. I mean, we don't know for sure, but that could be what that is. On exam, he's hypertensive, but otherwise his vitals are normal. He's alert. He's completely oriented and appears, well, which is not uncommon in syncope cases, that they look totally fine. He has this kind of annular white deposit on the cornea around the colored part of the eye that you see. That can be a sign of hyperlipidemia. It's really common in old people, though. It's kind of nonspecific. Otherwise, he's got the poor dentition, and the real meat here is in his cardiovascular exam. So he has JVD, which suggests elevated pressures in the right side of the heart. The point of maximal impulse is laterally displaced to the anterior axillary line, so meaning instead of being around the nipple area, it's all the way across towards his axilla, but still in the anterior thoracic wall, suggesting an enlarged left ventricle. The impulse is sustained, which can be seen with LVH. These are, and then there's an S4, which can be seen with long-standing hypertension and a stiff ventricle as well. There's a systolic murmur that's heard at the base of the heart, and it radiates up to the neck, toward the carotids. The two main systolic murmurs are aortic stenosis and mitral regurgitation. So this seems most consistent with aortic stenosis, which is really common in old people, even if it's not serious. It can often have mild calcification of those aortic leaflets with age, and you get this this type of murmur. This is a really detailed exam that's probably less common nowadays, but no right ventricular heave suggests that there's no enlargement of the right ventricle. But I could never really appreciate anything like this for me on exam. That's pretty advanced. So there are crackles heard in the lungs bilaterally, so that's a little concerning. He's got some expiratory wheezing, so potentially, could be pulmonary edema. It could also be he's a longtime smoker. Maybe he has COPD. And then he doesn't have any hepatosplenomegaly, and we're not told if there's any hepatojugular reflux. That isn't really reported. And then he does have some edema, but it's mild. I forgot to mention up here in the review of systems, he has this chronic dry cough, unchanged for years. That suggests, it's probably due to his smoking. Perhaps he has some underlying COPD, which would kind of fit with the wheezing heard on the lung exam, but doesn't really fit with the crackles or rales heard. And then his neurologic exam is normal, which is very common in syncope patients, that by the time you see them, their neuro exam is normal. So moving on to the clinical reasoning, we have the problem list here. He fainted, he experienced syncope and he was unconscious. He has a history of hypertension, probably untreated. He has some chest tightness. He has dyspnea on exertion. These are worsening for the last few months, concerning for accelerating angina. He has orthopnea and ankle swelling, concerning for CHF, although we don't know yet. He's a smoker and he has dry cough, so possibly some underlying COPD. He has this intermittent sore throat, which could be related to the smoking as well, and poor dentition. Sounds like he might have some BPH, potentially some osteoarthritis. And then on exam, he's hypertensive. He has these signs of aging in his eyes and potentially high cholesterol. And then JVD, which we already talked about in these findings, which we kind of talked about. So a sample problem statement would be Mr. Papadakis is a 72-year-old man with a history of elevated blood pressure and chronic tobacco use who presents following a syncopal episode in the setting of worsening dyspnea with exertion, orthopnea, and ankle swelling. So remember, in your problem statement, you always want to have the demographics, so the age of the person and their gender, if that's appropriate, and then start with their symptoms, so what they're telling you. So he has this history of elevated blood pressure, he has a history of smoking, and then his symptoms over the last few months. And then move on to your objective findings. So on exam, always include your vitals. Okay, you don't have to include them if they're normal, but please mention abnormal vital signs. It's really important. That's why they're called vital signs. And then the cardiovascular signs that we already heard. So I'd say this is concerning for aortic stenosis, given that it's a very common valvular disorder. He's older, that's when people get it. He has a murmur that's consistent with aortic stenosis, and he has potentially some of the complications of aortic stenosis, including angina, syncope, and CHF. We don't know yet, but that's kind of what we're thinking.